So good morning to all. So I'm also a localite. I am from Kottayam. So you basically, someone had told about me. So my training is basically in non-invasive brain stimulation, not just TMS, ECT, transcranial electrical stimulation, and also a developing field of psychiatry called interventional psychiatry, where brain stimulation is one of the core components. Brain stimulations, as you know, there is invasive and non-invasive stimulations, and other areas of this new branch of psychiatry include the psychedelic treatments, which is coming up, like MDMA, psilocybin, and other newer treatments. Then a lot of new medications are coming up, like already you might know about ketamine and its uses in psychiatry and other things. Then there are now new medications like brexanolone and other implantable drugs that is coming. Then a lot of growth is happening in the field of digital therapeutics, like that is like wearable devices, apps which can deliver therapy, such things. And another new area in clinical psychology is assisted psychotherapy, where you can use medication to assist psychotherapy or even brain stimulation to assist psychotherapy. So we will be just talking about brain stimulations today. So all of you know that brain is a chemo electromagnetic organ. Most of us know it as a chemo and electrical organ, and most of our treatments that actually addresses any sort of brain disorders either alter the chemical activity or the electrical activity, and both are like interrelated. So for the proper electrical activity of the neurons, we need to have the proper neurotransmitter system and second messenger system, and vice versa. Similarly, so we can actually measure the chemical activity of the brain using different imaging techniques like positron emission tomography or MR spectroscopy, and even BOLD in functional MRI. Then the electrical activity is what we actually measure in our EEG. Basically, it shows the intrinsic activity of the neuron, something called the neuronal oscillations that we can measure using EEG, and even rated potentials. And there is an intrinsic magnetic activity also for neurons because of the intrinsic firings of the neurons, which can also be measured and altered. And most of the treatments basically alter any of these mechanisms. So the brain stimulation treatments also primarily target the electrical and chemical activity, but TMS can have an additional component of altering the magnetic activity of the neurons also. So brain stimulator, as you know, it can be either invasive or non-invasive. Invasive involves the deep brain stimulation, vagal nerve stimulation, and psychosurgeries. Basically used in nowadays, deep brain stimulation is one of the major interventions in movement disorders, and it is also FDA approved in depression or OCD. And psychosurgeries are also being used in epilepsy and other things. So coming to non-invasive brain stimulation, basically it is classified as convulsive, whether it can induce a seizure or not. All of us know the classical convulsive brain stimulation, that is the electroconvulsive therapy or the ECT, which has been there in the field for over 100 years now and still being used and modified, and probably a lot of research is happening in the field. A newer version of convulsive therapy is the magnetic seizure therapy, where instead of electrical stimulations, where you can use magnetic stimulations. And the non-convulsive involves TMS, that is transcranial magnetic stimulation, transcranial electrical stimulation, transcranial ultrasound, and using light for the treatment, that is photobiomodulation. So we will be talking about TMS today. Just about a brief history, you know that transcranial magnetic stimulation is based on the Faraday's principle of electromagnetic induction, which simply means that a rapidly changing electric field can induce a magnetic field which is perpendicular, and a rapidly changing magnetic field can induce an electric field. So the first TMS devices was actually developed by Anthony T. Barker in UK. It was in 1985. It was published as a small letter to editor in the Lancet. And over the last 30 years, the number of publications related to TMS has grown to 25,000. So that much of research is happening in the field of psychiatry, neurology, and other branches of medicine. So simply, the TMS device is like this. It has a stimulator. So it has a stimulator and a coil. The stimulator actually draws the power and produces the magnetic field, and coil actually emits the magnetic pulses. So this is what is happening. It actually draws a very high energy, somewhere around 10 kilovolt, And the induced magnetic field is also in the range of 1.5 to 2 Tesla, which is similar to most of our older MRI devices. And it can induce an electric field inside the brain, which is of the strength around 140 to 240 volts per meter square. And the magnetic pulses can penetrate somewhere up to 4 centimeter in the cortex, and there is negligible field beyond 10 centimeter of the coil. So what happens is basically, even though it is called transcranial magnetic stimulation, the actual process is basically it induces an electric field inside the brain, but using magnetic pulses. So it bypasses the resistance of our scalp and the bones and the hair and the dura, and helps inducing an electric field very fast in the brain. So you can see the black circle is the current flow in the TMS coil. The dotted green lines are how the magnetic fields will be. So it will be perpendicular to the coil, and the red circle inside the brain is something called the induced current, also known as the eddy current. So which will be the force that actually bring about the changes in brain because of the TMS. So you can again see the violet dotted lines, which is the magnetic field. Just look at the enhanced image. So the dotted lines are, the purple dotted lines are the induced magnetic fields, and the blue arrows are the direction of the induced electric field. The green arrow shows an axon or a neuron. The neurons which are at an angle to the induced electric field will get activated with TMS. That's why if you give a TMS pulse in your motor cortex, your hand or leg will twitch because it can induce an action potential. So this is what happens exactly in the neurons. It induces a local depolarization in the axons, which mostly in the neurons which are at an angle to the induced electric field. This local depolarization will send impulses down and probably producing the activation of the neurons via producing an action potential. That is the major difference between transcranial electrical stimulation and magnetic stimulation. Transcranial electrical stimulation is not strong enough to induce an action potential, but TMS can induce an action potential in the neuron. So this is how different TMS coils are. The circular coil is basically used in investigational purposes, where you can actually use it along with electromyogram or EMG or EEG, basically for investigational purposes. The most commonly used therapeutic device is the therapeutic coil is the figure of 8 coil and the double cone coil, which can be kept on the surface of the brain. And the deep TMS coil or the H coil is actually copyrighted to one company called Brainsway. They only have this helmet type deep coils, which can even reach your basal ganglion regions. So can be potential use in movement disorders also. So a TMS train usually looks like this. There is a TMS pulse. Then it will be repeated at a specific frequency based on whether you want to increase the activity of the brain region or decrease the activity. And if the frequency is less than around 1 to 2, it is called the low frequency, and if it is more than 5, it is called the high frequency. So a train is in a small period like 1 or 2 seconds for which you will be giving the pulses, and there will be a gap between the train called the inter-train interval. And a session involves a longer duration of treatment, usually lasting from probably 3 to 10 minutes. And a session is basically a session of the treatment. So the TMS again can be classified as like single pulse TMS and paired pulse. Then the RTMS, which is known as repetitive TMS, which is known as the RTMS. It can be either low frequency or high frequency. And there is something called a new form of TMS called the theta burst stimulation, which is one of the patterned TMS. So this is the single and paired pulse TMS. Mostly used in investigational purposes, basically studies where you can look at the cortical reactivity markers. We know that there are different inhibitory and excitatory systems in the brain, like the GABAergic and glutamergic system, but it is very difficult to measure it directly how this activity is. One indirect way of looking at it is by measuring something called intracortical inhibition and intracortical facilitation. So TMS can be combined with electromyogram. For example, you give a TMS pulse in the hand area and record EMG from the fingers, and you can actually measure something called motor revoked potentials, which can be used to measure the different markers of intracortical inhibition, which is an indirect marker of GABA, and intracortical facilitation, which is an indirect marker of glutamate, and cortical silent period, again an indirect marker of GABA B. So basically used in investigational purposes, especially when you are looking at the brain processes in healthy individuals and you want to see how it is different in a disorder, etc. Now we can actually combine TMS with EEG, something called TMS evoked potentials can be elicited. It is just similar to our event related potentials in EEG. So it can also be used along with TMS and can be used in any brain regions like the frontal cortex, temporal cortex or occipital cortex, and see how a TMS pulse or a activity can change the brain in real time. So basically it gives a temporal measure of plasticity. So we will not be discussing in detail about that. This is what RTMS looks like. Low frequency TMS means pulses will be repeated at a 1 Hz frequency. High frequency will be like based on the frequency that you set. If you look at the theta burst stimulation, you can see that what is repeated here is something called a burst pulse, which actually has 3 pulses inside it at a very high frequency. And the bursts are repeated at 5 Hz. 5 Hz is basically in your theta range in EEG. That's why the name theta burst stimulation. So there are 2 types, continuous and intermittent theta burst stimulations. So accelerated TMS is one of the new fast treatment in psychiatry and neurology, where you give multiple sessions in a single day. So one of the recently FDA approved protocol for depression is something called the Stanford Neuromodulation Treatment or SAINT protocol, where they had given functional MRI guided TMS 10 sessions per day for 5 days with a response rate of 90% in depression in people who are like resistant to 4 to 5 antidepressants. So it is basically a personalized accelerator protocol where you can give multiple sessions in a day for a faster response, which is very crucial for us psychiatrists because most of our treatments are like takes time for the clinical effect. So accelerated TMS is one of the new things that is happening in the field of TMS. So just for the sake of explaining how we can plan a TMS sessions, this is one of the simplistic way of explaining it. A high frequency TMS or a intermittent theta burst stimulation can excite the brain. So if you keep it in the frontal cortex and give high frequency TMS or ITBS, it can increase the excitability of the cortical region. So in any disorder, if you want to increase the activity of the region, you can use either high frequency TMS or ITBS. So if you want to reduce the activity of the region, for example, in some condition there's a hyperactivity of your frontal cortex and you want to reduce the activity, so we can look for an inhibitory protocol. So inhibitory protocols are either low frequency TMS or CTBS. This is basically simply to help us probably plan a TMS session. Just a few words about the mechanism of action. So the immediate effects are because of the induction of LTD and LTP, basically the synaptic plasticity. Mostly the immediate effect usually lasts for somewhere around 30 to 60 minutes, and the long term effects are because of changes in the neurotransmitter system, second messenger system, and even the genetic apparatus. So this is how we can explain how TMS works. So the induced electric field can induce a synaptic plasticity, and it can influence the neurotransmitters and synaptic plasticity, which is one of the mechanism of TMS. Then the induced magnetic field also can influence the neurons, because neurons itself have something called the spin effect and quantum effects, which can be influenced by the induced magnetic fields. This can also, basically the long term effect of TMS are supposed to be because of the magnetic effect also, and there can be combined effect. That's how the long term effect of TMS on the neurons or any other part of the brain or body happens. So it can have both effect of magnetic component and electrical components. So regarding the safety, any metallic implant inside the brain like a DBS or a vagal nerve stimulator or even a bone anchored hearing aid is a contraindication, because if it is ferromagnetic, it can get damaged and there can be problems. Any metallic object within 10 centimeter of the coil is also a contraindication. And we usually avoid TMS in people who has a ferromagnetic implant in the neck also. It is very safe in pregnancy, children and old age, and hearing protection is recommended for patients as well as the TMS operators because of the high frequency sound. And operators are advised to keep a 40 centimeter distance from the coil, because we don't know about the magnetic effect of magnetism on human body. Like we don't have exact idea how it can have a long term effect also. So TMS adult safety screen is a simple screening tool for making sure that patient does not have a contraindication. And regarding the adverse effect, the most common adverse effect is headache and probably pain at the stimulation site and muscle twitches. One of the rare but serious adverse effect can be a risk of seizure, because it can induce action potentials and stimulate neurons, but it is very rare. It is less than the natural incidence of seizure, and as of now there is only 41 reported cases of seizure. And second can be, especially when you are treating bipolar disorder and depression, there can be a risk of affective switch. A person can switch from depression to mania. But recent studies have shown that this risk is very less, very negligible compared to the medications, and there was no significant difference between true and sham treatments in clinical trials in terms of affective switch. This is the number of the seizures reported. Most of the seizures were reported in treatments of psychiatric disorders, because most of the clinical users are in psychiatry. And deep TMS might have an increased risk of seizure. Even though it is less, there is one of the definite risk. That's why we have to operate TMS in a clinical settings where you can have emergency treatment options also. This is basically a simple tool to measure the side effects. So this is basically about the mechanism and the basic physics of TMS. So basically TMS clinical use involves selecting a patient. You should have to have a patient with the right indication. Then selecting a protocol. You have to choose a protocol based on the neurobiology of the illness. Then we have to estimate the dose. We have to find which cortical area to stimulate. So it is called the cortical targeting. Then you give the stimulation and monitor. So patient selection and screening involves based on the diagnosis and indications. And also we have to see whether there is any potential contraindications, and we may have to measure some sort of symptom severity to see how the symptoms improves with treatment. So choosing a protocol, as I had mentioned before, we have to use this idea to choose a protocol. So if you want to excite an area, choose either high frequency TMS or ITBS. Or if you want to inhibit a brain area, choose low frequency TMS or CTBS. And if you want to give, if you are looking at a faster response or a faster symptom reduction, we can choose accelerated TMS. So dose estimation is basically by measuring something called the resting motor threshold, or RMT. So it is basically, what is RMD is, you give TMS pulses in your motor cortex and look for muscle twitches. Either you can look for muscle twitches or you can use an EMG to record it. So the minimum intensity needed to produce the twitch is known as the resting motor threshold. And if you are using EMG, it is the 50 microvolt response. And most of the time the treatment is given at 90 to 120% of the RMD. For example, if the RMD is 35, we may choose a dose between probably 30 to 40. Based on the patient's tolerability. The TMS safety beyond 120% of RMD is not established yet, so most of the time we may have to limit the doses at 120. So how do you locate the different cortical regions? For example, if you want to locate DLPFC, there are some anatomical methods which is like obsolete now. These are something called 5 centimeter rule and 6 centimeter rule, where you measure the brain or brain areas based on some anatomical landmarks. One of the easiest way to locate brain area is basically by the 1020 EEG system. For example, the F3 and F4 corresponds to the left and right DLPFC. Like that, the 1020 EEG convention can be used for the marking the different brain region. Then I think neurosurgeons and neurologists might know about neuronavigation, where you can take a structural MRI of the patient, then locate the area that you want to stimulate. For that, we can use the MNI coordinate, the Montreal Neurocognitive Institute coordinates, and exactly localize the brain region. And one of the recent advances is personalized TMS, where you take a functional MRI, identify in each patient which is the circuit which is involved, and modulate that using TMS. So these are two softwares which is basically used in 1020 EEG, BEAM, F3 and EEG, freely available softwares where you have to just put the nasolabial, intertracheal and head circumference distances, and it will show you how to mark different points. A coil placement is basically, if it is short protocols, you can use your hand to hold the coil. Mostly we recommend to use the handle which comes with the TMS device. And now we have something called the robotic arm, where we can attach the robotic arm along with movement sensors. If the patient moves to one side, the robotic arm moves by itself to prevent slipping of coil. Even there are softwares for simulating the TMS protocols. SimNibs is one of such software, where you can, like if you want to plan a treatment in a new brain area where there is no much evidence or research, we can plan it on the patient's structural MRI, take the structural MRI, load it in the softwares and place the coil and choose the protocol and see whether it is exactly stimulating the brain region that you want to stimulate. For example, in the first image you can see the red color is basically on the left DLPFC. Left DLPFC is in the middle frontal gyrus, and the last one, it is the right orbitofrontal cortex, which is basically in the base of the brain. So we can plan it based on simulations and then go to the treatment part. So this is basically what I wanted to discuss with you. We will not be discussing any investigational use of TMS, but mostly the clinical applications. Most of you might know TMS in terms of its use in psychiatry, but it is not so. A lot of use is coming up in other fields, especially all sort of non-invasive brain stimulations and non-invasive electrical stimulations. It is actually gaining momentum in many fields of medicine. So that's what I will be discussing about. So we will be discussing about its use in psychiatry, neurology, physiotherapy, speech and hearing, ENT, ophthalmology, clinical psychology, ortho, and few other departments. So TMS is known for its use in psychiatry. So it has multiple FDA approved indications in psychiatry. The first was for treatment-resistant depression. It was approved in 2008. Then depression with comorbid anxiety. Recently in 2023, it was approved for the treatment of adolescent depression. Then treatment-resistant OCD and nicotine use disorder. These are the FDA approved indications where there is a high level of evidence. This is just the different protocols. I'm not going deep into it. Most of the depression protocols are excitatory over the left DLPFC. In OCD, most of the protocols are inhibitory and basically targeting either any of the corticostriato-corticothalamic loop, the CSTC loop, which is involved in OCD. So these are some other indications where we can use. Anything above level C can be used in so the strength of evidence level C means it is basically from probably some of the observational studies or retrospective studies. Level B is basically from open label studies, and level A is from good quality RCTs. So if there is a rare indications or if there is a critical indications where other treatments have failed, anything with level C can be tried on patients when there is no other treatment options are there. So anything with level C can be used in clinical settings also. So these are the other indications where you can use TMS. In schizophrenia for the persistent auditory hallucinations and negative symptoms, in substance use disorders, in PTSD, OCD, and fibromyalgia. So coming to neurology, one of the FDA approved indications for TMS in neurology is basically for the treatment of acute migraine. This is a portable device, as you can see, it's a small portable device which can produce low frequency TMS, and it actually targets the occipital cortex. It can terminate an acute attack of TMS, also can be used in the prophylaxis. This is a portable device. Multiple companies already have FDA approval for this device. And this is one of the FDA approved indications in neurology. For neurologists and psychiatrists, one of the most common symptom pool that may come to our OPD will be the non-specific pain symptoms and probably the paresthesia and the all those set of non-specific pain symptoms. So neuropathic pain and fibromyalgia, it was a level A evidence, RTMS, especially targeting the motor cortex as well as the DLPFC. This is one condition where we may actually fail with medications. We may have to prescribe multiple medications like tricyclic antidepressant or SNRIs or even newer GABAergic drugs. Still the patients may not be satisfied. A lot of side effects can happen. So chronic pain is something where we can use TMS in neurology. Then again, stroke. One of the main challenge following a stroke is basically the hypertonia of the limbs or the muscles, which actually prevent a successful rehabilitation or physiotherapy. So TMS can be used to reduce the hyperactivity if you actually give an inhibitory TMS on the unaffected side. So also it can use to increase the activity of the affect, like increase the muscle tone in the affected side by using it on the affected side. So in post-stroke motor recovery, TMS is used a lot, and it has a level A evidence also. Then in Parkinson's, the motor symptoms of Parkinson's can be targeted by a deep TMS, and its use is also been increasing because of the non-invasive nature. So instead of directly going into probably a deep brain stimulation, this is something that we can try in patients who are not responding to medications. Then the treatment of post-stroke aphasia, where you may have to target the Broca's area. Then in multiple sclerosis for the lower limb plasticity. Then in all sort of dementias where there is a cognitive issues, we can use excitatory TMS over the prefrontal cortex or even the cerebellum to improve the cognitive functions. And there are even uses of TMS in epilepsy, where it can reduce the number of seizures. So array of uses are there in neurology. So in physiotherapy, as I had mentioned, it is very useful to reduce the hypertonia of the muscles. So it actually helps in successful physiotherapy planning for following a stroke, in plasticity, in spasticity of the following in multiple sclerosis, in bradykinesia in Parkinson's disease, chronic pain, and the picture shows a peripheral magnetic stimulator, also known as the peripheral nerve stimulation. This is a recent FDA approval for actually it's not a TMS, it's a peripheral magnetic stimulator for low backache and chronic pain, where you can give magnetic stimulation over the affected area. It basically stimulate or activate the nerve roots in the spinal cord, and it can reduce the pain and other symptoms. So this is one of the recent FDA approval in for PNS. So in speech and hearing, one of the main problem ENT people and speech and hearing people might face is the chronic tinnitus, which may not respond to TMS. So inhibitory TMS over the auditory cortex has found to be useful in treatment-resistant tinnitus, and then also it is useful in post-stroke aphasia and sensory neural hearing loss. And ENT also same way. It has been found to be useful in post-stroke dysphagia, where the swallowing can be difficult. The target is basically the lateral precentral gyrus. So ophthalmology might be like a surprise for many, but a lot of work is happening in terms of non-invasive electrical and magnetic stimulation in ophthalmology, especially for retinal and optic nerve disorders. You might have known that a lot of transorbital electrical stimulation devices, transorbital ultrasound devices, all are coming up. For magnetic stimulation in amblyopia, occipital cortex TMS has shown to have some evidence in the treatment of amblyopia and the post-stroke hemianopia, optic neuropathy. In glaucoma and other disorders, the evidence is still less, but still there is something called transorbital magnetic stimulation, where instead of brain, we can target the orbital tissue itself for some disorders, just like transorbital electrical stimulation. So its use is basically improving in ophthalmology also. So in psychology, clinical psychology, as I have mentioning, so there is something called brain stimulation assisted psychotherapy, where the patients can undergo the TMS before or after the clinical psychology interventions, or even during the stimulation itself, during the session itself. So it can be combined with CBT, exposure response prevention, or in PTSD with exposure therapy. So it can be combined with the psychotherapy, and it has been shown to have improved efficacy than the psychotherapy alone. In orthopedics, a recent study had shown that it can be even useful in osteoarthritis pain in the knee and hip, where you can give local magnetic stimulations. So as I was mentioning, the peripheral magnetic stimulator can be used in low back pain. Its use is basically improving in complex pain and other things, and osteoarthritis pain, and even in rehabilitation after surgeries to reduce pain and recovery, the magnetic stimulation is being used, even though the level of evidence is low. Coming to urology. In urology, one of the major challenge can be an overactive bladder symptoms and urinary incontinence. And recent studies have shown that TMS can be useful in neurogenic bladder and urinary incontinence and overactive bladder, even though the level of evidence is less. And in gynecology, for pelvic floor disorder like chronic pelvic pain and incontinence, and also very good evidence for postpartum depression. So basically the use of magnetic stimulation is basically expanding from psychiatry to other departments also. This was just a glimpse of what is happening in the field. In the last few slides are basically research, like the research is happening in the field, and most initial slides basically shows where the level B evidence is there, which shows that already it is being in therapeutic use. So what is going to happen with TMS? We are moving into a field called precision TMS, where we will be able to target the specific area which is dysfunctional in each person through EEG as well as functional MRI. We will be able to locate which area has to be treated, especially in psychiatric disorders. Then personalized TMS will be working along with TMS, ENG, and functional MRI. There are something called MRI compactable TMS devices where we can give treatments inside the MRI machine. And there are something called MRI compactable EEGs where we can record brain activity inside the MRI machines, which will give you a real-time look at what is happening in the brain with the treatment. Then there is something called closed loop TMS where you feed back the information, like you record an EEG, give the TMS and see how the EEG changes and feedback to the stimulation to change the stimulation. Then all the current TMS devices are big devices which is like needed in very heavy and you cannot move it around. A lot of work is happening in terms of portable TMS where probably we may be able to give TMS at home, because especially in the treatment of depression or dementia and other things, it is not possible for the patient to come to the hospital every day to get the session. So a lot of work is happening in terms of portable TMS also. So just to summarize what we were discussing, even though TMS has been there in the last 30 years, its use is basically expanding into the other fields of medicine also. Initially, it was focusing only on neurology and psychiatry. Most of the initial TMS researchers are actually neurologists, people like Lee Fosher, who actually made the IFCN guidelines for TMS. IFCN is the International Federation of Clinical Neurophysiology, and which actually proposes the guidelines for all the non-invasive brain stimulations, EEG, EMG, etc. So most of the initial TMS researchers are actually neurologists and neurosurgeons, and also psychiatrists. So the use is basically expanding to psychiatric disorders and beyond, but it is not a cure for all, just like how ECT was used in psychiatry probably 50 years back. For everything we were used to use ECT because there was no other treatment at all. But it is one of the safest treatment in psychiatry, especially in psychiatry, because many of the psychiatric treatments has adverse effect. In that terms, it is one of the safest and it is one of the most evidence-based treatments. But we need to have a lot of training that has to happen, because most of our clinicians are not trained in the TMS. I don't think so. Neurologists are also trained, because they may have to go for another course to do it, because I don't think any of the teaching hospitals in Kerala has a TMS device. And there is a need for regulation of practice, because otherwise, as private practitioners start to use it, especially this is happening in other places, because the cost of one TMS session in Delhi is somewhere around 10,000 rupees. So for a depression, you may have to pay around 2 lakhs or 3 lakhs to complete 20 to 30 sessions. So a regulation of practice is also needed, especially in terms of who can use it, in which all conditions that can be used, and also in terms of the money that can be charged. So it should not be like this. So this is about TMS. This is about me. Thank you.
Thank you, Jithin, for a very comprehensive and extensive presentation. Now the topic is open for discussion. I presume you all got an idea as to how varied and how diverse TMS can be used in medicine in future. So now the topic is open for discussion.
Dr. Jithin, thank you. It was a very interesting presentation.
Thank you, sir.
Do you have any short-term follow-up of the results of treatment, or do you?
Yes. So we have been using TMS in KMC for the last 3 years. I myself have given more than 6,000 TMS sessions. So we primarily use TMS in treatment-resistant depression, OCD, and PTSD. We have a very good evidence in clinical trials where we actually look at extreme treatment-resistant depression. The response rate is somewhere around 50 to 60%. In real clinical settings where we use it as a treatment, especially in treatment-resistant OCD and depression, where we use accelerated TMS, we are seeing very good effect. Probably 7 or 8 people out of 10 is improving. One thing that we see is basically many patients are told that with TMS they had the best recovery. We had a few patients who has been on treatment for long years. Then some of the patients we are keeping in maintenance TMS also because they had a high risk of relapse. And we had one patient who has been on TMS for the last 3 years. He was a patient with a young stroke at the age of 17. Then he had a cardiomyopathy at 40. Then he went to receive a pacemaker. With pacemaker, we gave the TMS, and the one thing that he was told about, he was like now 57, I think. 54 to 57 was like the best time in his life because most of the time he was in hospital. So in terms of safety, it is very safe, and we see very good results in these conditions. But only thing is we may not be able to use it like for anything and everything. We have to have the right patient, right indications, and most importantly the right way of doing it because it's a procedural treatment. So one thing that we see is the cortical targeting is the most important step, because if you miss 1 centimeter in the DLPFC for depression, you may not see the actual clinical effect. That has been proved in a lot of studies, because DLPFC is basically around 1 centimeter into 3 centimeters strip. So if you just move it to the left or right, it can miss the DLPFC. So the cortical targeting is the most important step. In many clinics, the nurses or the technician just keep the coil on somewhere and give the treatment, and they may not see the much result. But if you do it in the correct way, we are seeing very good effect. We have treated few patients with stroke also, and a few patients with Parkinson's, especially for both motor symptoms as well as the depressive symptoms.
You combine that with medication also?
Yes, medications most of the time, if it is a clinical trial treatment, we keep it a stable dose. If it is a clinical treatment just for the condition, we can co-prescribe medications. But most of the time, patients will be resistant to the medications. Sometimes they may not be on medications. So we either stop or keep it. But recent studies have shown that combined use of medication as well as TMS, especially in depression and OCD, has a better outcome, because TMS can actually change the neurons or make it more susceptible to medications, just like the theory that we used to tell in ECT also, whether some patients start to respond to medication after ECT. Similarly, because the medication also works on many of the active neurons, because of the neuroprotective nature of TMS, it can even even generate new axons and dendrites. Probably maybe the reason why better medication effects is there. But most of the time we get extremely treatment resistant patients, so we keep it, the medication does not matter because they are not responding to the medication itself.
Thank you.
Yes.
Maybe it's time we got a machine.
Yeah, I think Suman wanted to put it in that way also. For a teaching hospital or a private hospital, buying a TMS machine for a single department is not at all economical, because it has to be economical also. Because most of the TMS machines cost somewhere around, the Magvenger machine costs somewhere around 1 crore now. The Brainsway machine costs somewhere around 2 crores. And there are cheaper machines, but if departments actually use it together, like neurology, psychiatry, physiotherapy, speech and hearing, these are the different departments that they can use it right now. They can use it right now for different conditions that they face in everyday clinics. So when departments pull together and buy a machine, it is feasible, and it is basically economical also. And you have to change the coils. The coil has a validity, mostly 3 to 5 years. The magnetic pulses usually get exhausted after probably 3 to 5 years, and you have to change the coils.
Thank you, Dr. Jithin, for the wonderful presentation. One of your slides was mentioning around 21% increase of stroke. Is there a chance like that, or is it among the side effects? One of the slides on the side effects, migraine and all that, and below that 21%.
No, that was about the seizure, no, sir?
Stroke 21%, it was saying.
This one, no? This is not stroke, this is basically about seizure.
Okay.
This is the 41 cases of seizure that was reported. So the most common adverse effect of TMS is basically the local discomfort that you have during the stimulation. So I don't remember any patient who had discontinued TMS treatment because of the pain or discomfort.
Yeah, that stroke in 21% down.
That is the indication for TMS, sir.
Oh, okay.
For which indication TMS was used. So 57% was used in psychiatric condition, 21% it was used in stroke. Yeah.
My second question is for the room specification. If you have to have
No,
a
sir.
TP.
Any air conditioned room is fine.
Fine. No need of any.
Yeah. So the mission, so the mission, the newer missions comes with a intrinsic cooling unit.
Right.
So it will regulate the coil temperature. The coil temperature will go up, and any AC room is good. Any hospital room with a very good power supply, because it will draw a high amount of power. So that is enough. And the fluid cooled coils are like little heavy, and the newer coils are like air cooled and wax cooled, which is like lighter. So this is basically the machine, and this is basically the cooling.
So you don't need any MRI protection, or
No, if you have a structural MRI and a neuronavigation is well and good, because we can exactly localize the brain area.
Right.
So in each individual. So one of the best way of locating exact brain region is you take a structural MRI. We have structural MRI everywhere. Then put it in neuronavigation. Mark the DLPFC for that patient. For that we have something called MNI coordinates. But most of the radiologists know how to locate the DLPFC using. There are different techniques to mark different brain regions, not just DLPFC, any regions. Then you keep the coil there. With neuronavigation is very easy, because there will be a sensor on the patient's head and there will be a sensor on the coil also, motion sensor. So you just move it around. When it is exactly aligned at that point, the neuronavigation will become green. You fix it there and give the treatments. So that is one of the easiest and best way to probably use TMS by you taking a structural MRI.
So what is the total average cost? Around 2 to 3 crores?
No, this mission is actually, so MagVenger is one of the company which produces one of the best TMS missions. MagVenger is basically from Denmark. This mission is somewhere around 90 lakhs now, I think, in India, because it is being imported. The taxes and other things are like high. There is another company called Neurosoft. Their mission, the advanced mission, comes from somewhere around 40 to 50 lakhs. It's from Russia. Then the BrainsWay mission, where I had shown the helmet-like coil. BrainsWay is from Israel. That costs somewhere around 1.5 crores. And each coil for that deep coil is basically 50 lakhs. So you have to buy a different coil that is one disadvantage of BrainsWay. So there is something called a depression coil, OCD coil. So you have to buy each coil. So that is again 50 lakhs. So BrainsWay will be a little too costly for us, and it is basically used for specific indications. Advantage of using figure of 8 coil is you can use it in any areas. You can keep it on the front, you can keep it in the occiput, you can keep it in the prefrontal, like in the orbitofrontal region or temporal region, any region. So I will suggest to buy a figure of 8 coil, and probably with a butterfly coil which can reach little deep. Since I think there is postgraduates also, but one additional use of all these new treatments is basically research. We can do a lot of research, especially we can just look at MEPs following stroke and see how it is evolving with improvement of stroke. Or just look at MEP or use EEG also, see how EEG patterns change with treatments, whether it can be medication or just follow-up studies. A lot of research opportunities are there with the TMS, or not just TMS, even transcranial electrical stimulations also. In all departments, a lot of research can be done, especially very less work of this area from India. So it actually opens up a lot of opportunities for research also, not just treatment, a lot of opportunities for research when you are combining it with EMG.
Jithin, I have a question. So I just came to know that some centers are using TMS machines without professionals using it and technicians just using the machine. They have just heard one center in Ernakulam bought a machine for around 1 crore. They don't have any doctors there who are well trained in delivering the TMS services. So what is your look on?
That's what the last slide I was telling, that it should be like, so any sort of, as all of you know, interventional treatments actually need procedural training, because the procedure is the most important step. You might know everything about the theory part, But as I was telling, because so there was a recent study which looked at structural MRI based targeting versus 1020 EEG based targeting in depression. They found that in 30% of times, the 1020 EEG marking actually misses the actual DLPFC in that particular patient, which actually shows why it is very important to exactly localize the brain region. Very difficult for a non-trained person to do that. 1020 EEG system is very good for clinical use, but you have to do it in the right way, because you have to properly measure each measurements like your nasolabial distance, intertracheal distance, and head circumference, put it in the software and mark it properly. And you have to do it consistently. If two people are doing it, then the inter-rater reliability is also a big thing. Second is estimation of the dose. So estimation of the dose is very important, because the safety of TMS depends upon the dose. So for example, if a person's RMD is 40, you may wrongly estimate it as 50 and may give treatment at 120% of it. That is actually the 60% of the stimulator output. So which is basically almost 150 times for the particular patient, which can increase the risk of a seizure. There is a similar way you may actually underestimate the threshold also. So this can actually lead to actually maybe a subtherapeutic dosing. So the procedural part is very key, especially in all sort of procedural treatments. Doing it without proper training is not gonna benefit them also, because you will not see the clinical effects. After a point of time, patients will feel that they are not improving. The clinicians will feel that the patients are not improving, and finally it will end up like not used much. So the clinical, the therapeutic effect of any procedural treatment depends upon the procedure itself. So you have to have training. The problem is that in India, there is very few places where you get a training in non-invasive brain stimulation as part of your residency. And we may have to go for a additional fellowship or a certification course or an observership to get trained. But I think all the treatment should be monitored by clinicians. It is okay to actually use a technician to do the procedure, like keep the coil and other things, but each step should be supervised by a clinician, at least for in the initial period. Once a single technician or one or two people are doing it very well, then they can be used in the treatment. But all new patients should be monitored and planned with the help of the clinician itself.
Thank you. Any more questions?
Thank you for the excellent talk. I just wanted to ask about the safety of TMS in pediatrics and also during pregnancy.
Yeah. So in pregnancy, a lot of studies are being used already there. There is no additional pregnancy problems, but for example, if you are talking about postpartum depression and other things, or even peripartum depression, this will be one of the safest treatment, because it does not have any effect, because you will be stimulating the brain region and your uterus is somewhere around 50 centimeter down. So the strength of the magnetic field is actually inversely proportional to the cube of the distance. So as the distance increases, there is no magnetic field. So if the coil is here and there is zero magnetic field beyond 10 centimeter, probably neck, so it's absolutely safe in pregnancy. As I was telling, in 2023 there was an FDA approval for adolescent depression. So children who are like more than 14 years. In children less than 14 years, the problem is you may have to have specifically designed coils, because this coil will be too big for the child's head, and you may not be exactly able to localize the different regions. But its use is actually being increasing in ADHD, one of the conditions where you can treat, and autism, especially for the repetitive behaviors in autism. So the safety is established. Well, it is actually safe, and as with any treatment, there is always a question like what will be the long-term effects. But TMS is being there for the last 35 years. We haven't seen any long-term effects of TMS itself. So one concern is basically we were not much aware about the effect of, as I was telling, magnetism on bodies like our cells, because we don't exactly know how it will, because body itself has an intrinsic magnetism. So whether the TMS magnetic fields can change any of the organs or change any of the cells, and whether it can have a long-term side effects, we don't know right now. That's why the caution of the distance for the people who actually deliver the treatment. So otherwise it's very safe. It's very safe in older adults also, because especially when you are treating depression or any other conditions in people who are older, always a high risk of side effects like extrapyramidal symptoms or sedation and other things. TMS actually reduces a lot of it. And there is something called a 4D study, which actually is done in the institute that where I am going, University of Toronto, which basically is actually TMS for depression in elderly. So very big study. They found that is very, very useful for people, especially in geriatric depression also. It's very safe in elderly also. And is being increasingly used in the treatment of minor neurocognitive disorders and major neurocognitive disorders, all sort of dementias, behavioral symptoms in dementias, etc.
John sir, any comments from neurology? Thank you everyone for your participation. I hope we had a very enriching session and something to look forward for our institution also. Thank you, Jithin, and thank you everyone.